Amanda and others who are in the trenches every day. I appreciate you guys joining us and really hope we can have some discussion toward the end, because there's not really one solution to this nagging, indolent problem of congenital syphilis. So Julia's already reviewed my disclosures. I spend a lot of time in research and clinical trials, and I'm really focused now on moving our local pandemic response in North Louisiana to focus on endemic issues, particularly STIs. And that's a kind of a pet project of ours. We've just allocated almost $1 million in resources to make this pivot so that we can think about STIs differently and really try to change the dynamics of what's happening with STIs, including syphilis and HIV in Northwest Louisiana first, and then move it out, as if we're successful, to other parts of the state. So today we're going to talk about the epidemiology of syphilis and congenital syphilis. We're going to review the manifestations of syphilis in teens, adults, and infants, most of which you remember from medical school and nursing school. Talk a little bit about diagnosis and treatment. And if we have time, we'll review a few kind of challenging cases, because there is a little bit of black and a little bit of white in terms of how these cases look, but there's an awful lot of gray. And that's the challenging part for pediatricians to deal with. And that's part of why I'm here and other infectious disease doctors are available. We are your tax dollars at work as an LSU employee. So I'm happy to take consultation, phone calls, and the like in the challenging areas. So there's the data that came out of CDC just late last year in November, 10-fold increase from 2012 to 2022 in the number of cases of newborns with syphilis in the United States over 10 years. And this is, again, a trend we've been watching for quite a while, and unfortunately has not abated with the things that have been going on. Here's the case counts in the United States over a longer period of time, back to 23 years, 24 years now, from 1999. And you can see this rapid surge from 2015 to 2021 in this graphic of congenital syphilis in the United States. And in Louisiana, we have a parallel curve. No big surprise that our case counts have been paralleling that of the national. And in fact, Louisiana for more than a decade was the #1 state in terms of rates of congenital syphilis. And we have been surpassed now by several other states, but only because their rates are higher, not that ours are coming down at all. So, and when we look at those rates by state, this is the 2015 to 2021, just that big surge. I've got Louisiana here in the purple and gold, and you can see we were #1 in 2015, 16. By 2018, we had dipped down a little bit, and a few other states had passed us, but our numbers are continuing to go up. And this is rate, this is cases per 100,000 population. And in the 2022 data, we're still at third or fourth. I don't recall, because I haven't spent a whole lot of time in the specific numbers yet related to that. But our rates are going up, and other people's are going up faster than ours are. If you look even further back in history, go back to 1941, you can see that the rates of reported cases by birth year across the whole United States were extremely high in the 1940s and 50s, and they came down with the advent of penicillin, treating people, not just moms, but moms and dads and people in the community with penicillin. And our rates came down, and in 1991, we had a little bump associated with the crack cocaine epidemic and HIV spreading, and then we have come down, but now we're on the uptick again, and we're right at the same level of case rates of congenital syphilis that we had in 1991. And this is overall syphilis reported cases. The prior slide was congenital syphilis rates, and you can see those parallel each other. Not a big surprise. So when we look at congenital syphilis, we have to really think about it as that canary in a coal mine. It is an indicator of high rates of syphilis in the community. If we didn't have syphilis in adults, we wouldn't have syphilis in babies. Pretty straightforward there. And when we look at the primary and secondary syphilis case counts in this subset of the U.S. population, we can see that more cases occur in Caucasian and African American patients, women and adults, but yet the rates of cases are higher in American Indians and Alaskan Natives at almost 65 cases per 100,000. So there's a disproportionate effect of syphilis in people of color and indigenous populations in the United States compared to the Caucasian population. The numbers by sex are shown here, and it's not a big surprise that the rates are highest in men compared to women, and this is still largely driven by men who have sex with men. What we're seeing over time, though, and I think the next slide I'll show it in a minute, the rates in women are still increasing, and what we're seeing is that ratio of male to female cases has come down steadily over the past 5 to 7 years. And what that means is, whereas there used to be 5 or 8 or 10 cases in males compared to 1 in women, now the ratio is about 2 to 1. 2 cases in males to every 1 case in women. And in our area of the state, that ratio is almost 1 to 1. Almost a 50% of cases are in women and 50% in men. So that's an indicator of the changing epidemiology, the changing demographics of syphilis in our communities. This is occurring in all regions of the United States, and you can see out west the rates are higher than they are in the southern states, but the southern states have a little more rapid increase over the past several years. And here's that graphic to show you, the sex of patients with syphilis as well as sex of sex partners. And again, men who have sex with men is this large maroon color in the graphic. And so if you look back at 2013, 2/3 of the cases were in men who have sex with men, and 1/3 of the cases were in women or men who have sex with women. But now advanced up to 2022, and you can see that now it's less than half of the cases are in men who have sex with men, and somewhere close to 1/3 of cases are in women or men who have sex with women. That increase in the heterosexual population is part of what we're dealing with now, because the heterosexual population is also the reproductive population. Here is a graphic that shows over time, and it's going to advance in color. You can see we started in 2012 with Louisiana having the highest rates of primary and secondary syphilis, and now everybody else has become a darkened blue color indicating high rates of syphilis, except for a few places out west where there are still more cattle than there are people. But the bottom line here with respect to congenital syphilis, as I said, it's a canary in a coal mine. And this graphic shows 2 things: the number of congenital syphilis cases in the blue blocks increasing up to 2022, and the rate of primary and secondary syphilis in the black line among women in their reproductive years, age 15 to 44. Now, we know reproductive years can start a little earlier than that and may last a little longer than that, but that's the primary. And you can see the exact parallel. As the rates of primary and secondary syphilis in women of childbearing potential increase, so do the number of congenital syphilis cases. That makes it easy to answer the question, how can we get rid of congenital syphilis? We've absolutely got to tackle the problem of primary and secondary syphilis in pregnancy. So when we look at the data about cases of syphilis in pregnancy, you can see in the orange, these cases are increasing over time, over 8,000, almost 9,000 cases in 2022. And you can see that the ratio of women who have syphilis in pregnancy to congenital syphilis cases is consistent. About 1/3 of women who have syphilis during pregnancy will have a baby with congenital syphilis. So about a 2-to-1 ratio, 3-to-1 ratio here with respect to mom having syphilis. The likelihood baby gets congenital syphilis is quite high. And that's where we've got to begin to tackle things. When we look at congenital syphilis, again, looking at race and ethnicity, you can see on the left side of this panel, the percent of live births across the United States, annual birth cohort of a little less than 4 million. 52% of those babies are white. but 27% of those with congenital syphilis are white. And conversely, especially the African-American numbers, only 14% of our population is African-American. That is, the live births annually are African-American, but almost 30% of congenital syphilis cases occur in women who are Black or African-American, and a large proportion also in the Hispanic population. So you can see where the cases are, again, in people of color. This is consistent across virtually all sexually transmitted infections that we're dealing with in the current age. They're much more prevalent in people of color. And here again is that case counts and rates compared, and you can see that of the congenital syphilis cases, 1,100 in people, women who are Black or African American, almost 1,100 in Hispanic and Latino, and a little over 1,000 in women who are white or Caucasian. So the cases are predominant in people of color, and the case counts are highest, though, in people who are of other ethnicities or indigenous populations and the like. So this makes it challenging, because if we're going to go after the case counts, if we want the case counts to come down, we really need to focus on these on the larger population pools. But at the same time, we need to be aware that the rates are very high in American Indian and Alaskan Native populations. Also, the Native Hawaiian and Pacific Islander population, very high case rates. And here is congenital syphilis rates reported by jurisdiction across the United States. And Louisiana is sitting at about 200 per 100,000, so about 2 per 1,000 babies in Louisiana are born with congenital syphilis. Texas beats us in this rate. Mississippi, Oklahoma, this is Arizona, New Mexico and Arizona also have higher rates than Louisiana. And you can see that South Dakota also has a high rate, but very few births up there. Maybe that's because of all the oil business going on up there. I don't know. Good question. They have to keep warm somehow, I guess. And here is, when the rubber meets the road, what are we missing? How can we do better? So if we look at all 3,700 cases in 2022, CDC has done this, that 37% or almost 1,400 had no documentation of timely syphilis testing. So that's missed opportunities. Some had late seroconversion, and about 60%-ish had timely testing. So this is the 60% doing okay, but over 40% lack of timely testing. Now, when we break down those that had testing on time, the largest proportion, or 69%, had inadequate treatment. And remember, our treatment criteria, what's adequate, means that mom has started treatment with penicillin at least a month prior to delivery, not finished it, but started the treatment at least a month prior to delivery. And we look for other things like a 4-fold decrease in mom's titer. Well, if mom starts treatment 6 months before the baby's born, 6 weeks before the baby's born, her RPR titer may not be down yet. And it may not come down for 3, 6, even 9 months after starting treatment. And so part of this inadequate treatment is related to really later testing that is occurring. So testing, treatment, and then a few in terms of the clinical outcomes, harder to understand those with adequate treatment. We've had a couple of babies recently in our area where mom has had documented adequate treatment during pregnancy, but yet, or we've treated in the postpartum period for congenital syphilis, yet some of those babies will fail therapy, as some moms fail therapy as well and require retreatment. So that's where it gets really complicated, and that's why we're here as ID specialists for you. So in teens and adults, you're all familiar with this natural history of untreated syphilis. Primary syphilis, secondary syphilis. We'll look at a few pictures, but not too much. And this is the most infectious time period during primary and secondary syphilis. Neurosyphilis, ocular and otic syphilis can occur at any time point during the course of untreated syphilis. And we've had 2 young adults recently in the same month diagnosed with ocular syphilis by the same ophthalmologist. And so we're putting them on alert also to be aware that ocular syphilis may be the presenting symptom that identifies someone who has syphilis at some stage. And one of those 2 was in primary syphilis, and the other was in an early latent stage of syphilis. But this is the classic untreated natural history of untreated syphilis. And that incubation period, 9 to 90 days, means that you may not have an immune response, RPR or IgG titer, during pregnancy that is adequate enough to make the diagnosis in late pregnancy before the baby's born. So there's some challenges because of the long duration of this incubation period and before seroconversion occurs. So a few pictures. These are primary syphilitic chancres in different parts of the body, and I've masked a few of them because it's a lunch hour, but they can occur anywhere in the mouth and the genitals, and the perineum and anal area. Secondary syphilis can occur in the mouth, and have patches in other places as well, the rash of secondary syphilis. But most of us might look at this, a lot of people say, oh, maybe geographic tongue, or maybe it's a yeast infection or something else, or look at those tonsils over to the right. Yeah, that doesn't ring a bell for syphilis, but it sure could be. So this is where you have to have a high level of suspicion, especially in young adults, as we looked at the age breakdown earlier, with oral or genital lesions as an indicator. The rash of secondary syphilis you're all familiar with on the palms and soles. This is a crusty looking one. You can say, well, this guy just has poor feet hygiene. Nope, this is secondary syphilis, and this is a high rate of transmission of secondary syphilis. And also in the secondary syphilis category is the condyloma lata, a painless, fleshy, white growth. And we actually had a toddler with a condyloma on her back that went to the surgeons first for removal and pathologic evaluation, because they thought it was just a neurofibroma or something. And the pathologist called back to say, hey, this has spirochetes in it, y'all. Think about syphilis. And that toddler's titer of RPR was 1 to 128. She had postnatally acquired syphilis and already at secondary syphilis. So tertiary syphilis we won't see in the pediatric population, thank God, but you have to think about it in adults. This is rare, develops in a subset of untreated syphilis infections. We don't understand why some people develop tertiary syphilis and others don't. It can appear 10 to 30 years after infection. It can be fatal, and it can affect multiple organ systems as outlined here. And one of the most famous people to die of tertiary syphilis, you'll have to remember, is our bad boy Al Capone. Neurosyphilis, as I said, ocular and otosyphilis can occur at any stage, so it can be associated with primary or secondary syphilis. It's not just tertiary syphilis. So who should receive syphilis testing? Who should be tested? Any person with signs or symptoms suggesting syphilis should receive a test. Anyone with oral, anal, or vaginal sex partner who receives a recent diagnosis, that would be a very high-risk situation. Anyone who's sexually active should discuss their risk factors with a healthcare provider, and you have to ask. You have to get down to the details, especially with teenagers and young adults that some of you may be seeing. And then routine testing should occur during pregnancy for all men who have sex with men, anyone with HIV who is sexually active, and anyone taking PrEP for HIV prevention. They've already self-identified as engaging in high-risk behaviors, and syphilis is part of the routine testing regimen for those who are on PrEP. Oops, let's see. There we go. All right, so how do we prevent syphilis? Well, we'd like to be on the left side of this, primary prevention, that is sexual health promotion, education, promoting condom use. I remind people routinely, condoms, bicycle helmets, seat belts, and vaccines all reduce risk. They are risk mitigation strategies. None of them are perfect, but they do reduce risk. And when it comes to syphilis, transmissibility is very high during primary syphilis. If a person has a syphilitic chancre, their likelihood of transmission to a sex partner who does not have syphilis is well over 50%. And so likelihood from a single sexual encounter. Most of what we're dealing with now is secondary prevention. Obviously, asymptomatic infection tends to be a big problem with all the STIs, and we have to test more to identify asymptomatic infection. Symptomatic infection is a little easier because the patients are identifying themselves as something's not right down there, and we can make a pretty good leap of faith and say, okay, let's do some testing. But it's this asymptomatic group that continues to spread sexually transmitted infections, including syphilis, that is the most challenging for us to get to. When it comes to congenital syphilis prevention specifically, obviously, we've got to think about women as more than half the population, especially women infected with syphilis, because those are in the childbearing age become pregnant women with syphilis. And really what that means is prenatal maternal screening, and we'll look at that. And then case identification, again, congenital syphilis itself, it represents a failure of the system to protect our babies. In Louisiana, we are one of a few states that, go back one, that requires first testing for syphilis during pregnancy. Requirement is for 2 tests, one at the first prenatal visit, whenever that is, one during the 3rd trimester, and an opt-out or judgment call by physicians about whether to do a 3rd test at delivery. And we really want to encourage doctors to do the delivery test, because what we're seeing as part of that failure of the system is that sometimes late infection, if a woman's infected during the 2nd trimester or even early 3rd trimester, they may not seroconvert for a few months and have already had a negative test in the 3rd trimester and then be positive at delivery. So all of the dynamics of the immune response are relevant here, and we want to do more and more testing during pregnancy to really aggressively identify women who are at risk and therefore babies at risk, so that we can prevent congenital syphilis. Where is it failing? We talked about lack of timely testing and inadequate treatment being the 2 biggest categories. Some parts of that inadequate treatment we can't correct, even if mom's been tested multiple times, but seroconverts in the 3rd trimester and starts treatment and delivers the baby 2 weeks after that, then that's going to fall in the category of inadequate treatment, and that baby will likely need a full evaluation, actually will need a full evaluation, and either a full course, 10 days, or a single dose of benzathine penicillin to prevent progression in the baby, depending on symptoms. So your evaluation of possible congenital syphilis includes an RPR with a titer, not a syphilis IgG. Syphilis IgG will be from mom. Doesn't help us at all in terms of the baby. So got to have an RPR, CBC, chemistry panel, long bone x-rays, ophthalmologic exam, hearing test, absolutely, and an LP for routine studies, including a VDRL to look for evidence of neurosyphilis in the babies. This is the standard workup. Having a positive VDRL doesn't necessarily change management in terms of those 10 days, but it has implications for the developmental outcomes for the baby. And so that's part of the reason that we really strongly encourage, go ahead and do an LP, get that VDRL done, so that when child shows up at 3, 4, 5, 6 years of age and has learning difficulties, then we have some documentation of what may have been the cause of that in earlier in life. So what does congenital syphilis look like? Most cases are asymptomatic. The literature says about 50%. I think it's more than that. It's probably 60, 65% of cases are asymptomatic. And then those that are symptomatic will have a spectrum of disease, mild, moderate, and severe. The things that we routinely will see that are abnormal would be elevated liver enzymes, thrombocytopenia, those bone changes. All of those that are symptomatic definitely get the full 10-day course of IV penicillin, Pen-G. In the moderate cases, and of course at any time during pregnancy, you can have premature delivery provoked by primary syphilis in mom. We've seen a couple of cases this past year of primary syphilis during pregnancy provoking premature delivery, 28, 29, 30 weeks gestation. We actually had a case of primary HIV infection in mom, also provoke premature delivery. Those moderate cases will have more significant liver dysfunction. And then the severe cases, those babies can present with sepsis-like syndrome at birth, big liver and spleen, even multi-organ failure, and in severe cases, stillbirth. From a statistical standpoint, the data is fairly reassuring. Most of these babies have no symptoms in the bright green here, alive, but with some mild to moderate symptoms in the lighter green, and infant death and stillbirth are fairly uncommon. But the data looks like that graphic I showed you before, increasing numbers of cases, specifically of infant death and stillbirth related to congenital syphilis year over year. So when you look at this number of about 275 deaths due to congenital syphilis, either stillborn or infant death, that is rivaling the number of deaths that we're seeing annually from flu in kids and COVID in kids, not just in infants, but in all kids. So these numbers are not trivial, and obviously the increase is the bigger concern. So when it comes to testing and treatment, you're all well familiar with these algorithms. This is the traditional algorithm. We use the RPR as the primary screening test in this traditional algorithm. If it's reactive, we confirm it. The RPR, remember, is a non-treponemal test. It's not specific. And we confirm a positive RPR with a treponemal test, or a more specific test. Any one of the following of the ones listed here are useful. And if that's also reactive, then we confirm infection and we move to treatment. But that could be an indicator of previously treated infection. And so the history from the mom is always critical to interpreting the data that you have from an RPR as well as a treponemal test like an IgG or FTA. Causes of false positive RPRs is a long, long list. And this is why some people stay away from the RPR, because it could be a false positive. And look over here to the top right, false positive just from pregnancy. So pregnancy itself can give you a false positive RPR. But what you need to know about these false positives is that they're low false positives. They're 1 to 2, maybe 1 to 4. But if it's at 1 to 8, you cannot assume that's a false positive. And the only way you can make a judgment that an RPR is a false positive is by having a negative specific treponemal test. That is a negative syphilis IgG. And again, go back to the history. Does mom have a new sexual partner? Has the sexual partner been recently diagnosed? Are there any other risk factors to consider? Because the last thing you want to do is call it a false positive when it's really not. And then you end up with a situation where the baby may end up with congenital syphilis that doesn't manifest until the postnatal period. So be very leery of calling it a false positive based on mom's age, based on mom's race or ethnicity. We want to be just an open book and very clear that everybody should be tested regardless of station or state in life, skin color, age, number of babies, all of those things, and religious background. Everybody should be tested. In the newer called reverse sequence algorithm, we use a specific test first, the treponemal test, like a syphilis IgG. It's the most common one used. If that is positive or reactive, then an RPR is the follow-up test. So we just change the order of these tests. If the RPR is non-reactive, then we've got discordant results, one positive, one negative, and we need a third test, a TPPA, which is a send-out, takes at least 5 to 7 days to get the results of that back. And if it's your tiebreaker, if that's reactive, then we say, okay, yes, this is a situation of syphilis infection. If the syphilis IgG is positive, if we stopped up there and said, okay, that's syphilis, you can't tell if that's new syphilis or old syphilis. Everybody who's ever had syphilis, their IgG is always going to be reactive. And so you really have to do the RPR to understand, are they having an acute immune response to syphilis with an RPR increase of 1 to 16, 1 to 64, 1 to 128, whatever it might be. The challenge here is that if someone is in the stage of late or latent syphilis, that is past primary and secondary, their RPR may be reactive at 1 to 4. And their IgG may be positive because it's always going to be positive and they have a history of syphilis. So you can't tell in this situation whether that's burned out syphilis without treatment, which you still want to treat, or is it just carry over what we would call serofast, that is, they maintain a low RPR titer over time. So this is the nuances and the challenges of syphilis diagnostics. We really wish we had better diagnostics. And point of fact, what we've been doing is the same diagnostics for more than 50 years, and there hasn't been any improvement. Again, go back to first do no harm. In the case of syphilis, like tuberculosis, we know we overtreat syphilis. We know we overtreat tuberculosis. And part of that is because the risk benefit is such that the treatment is not so bad, penicillin. It can have complications, but the problem of missing the diagnosis is much worse, both from a public health and an individual health standpoint. So we know we overtreat. It's because the diagnostic tests are inadequate to do better. And so here's evaluating reactive syphilis serology, kind of pathway, and where are we looking at declining in titers or unchanged titers or a rise in titer. This is most important for us when we have a baby who has a titer of 1 to 2 at the time of delivery. We've treated or elected not to treat because we think that they've been adequately treated during pregnancy. Every baby who has been syphilis exposed during pregnancy must have an RPR before they leave the hospital, and in addition, an RPR follow-up at 2, 4, and 6 months at a minimum to assure that there is not a failure of treatment of mom protecting the baby, or that baby has a rising titer indicating congenital syphilis infection. So let me say that again. Every baby who's exposed to syphilis in utero must have an RPR at the time of delivery and follow-up RPRs. Even if the delivery one is negative, they need follow-up RPRs at 2, 4, and 6 months to assure that they have not do not have congenital syphilis. All right, penicillin is still our treatment of choice, regardless of age. In pregnancy, it is the only acceptable use, and it is the one time where we absolutely insist that moms who are allergic to penicillin and are pregnant must be desensitized and receive penicillin as their treatment for their syphilis. As I said before, in terms of the babies, for those that are low risk and we're comfortable that the follow-up is good, we may elect to treat them with, and we really think they don't have congenital syphilis, but we can't prove a negative. We may treat them with a single IM benzathine penicillin dose. Go for the red book. It has the exact dosing, 50,000 units per kilo times 1. Or if they're high risk, then we're treating with IV penicillin G for a 10-day course. And the dose changes at 7 days from twice a day to 3 times a day, depending as they grow and their kidney function improves. Okay, but penicillin is our gold standard still. And recommended follow-up, as we talked about, follow-up for adults, it should be at least 6 and 12 months for those who are HIV negative, and more frequently for those who are HIV infected, because they're more likely to have a failure of primary treatment. But for our babies, at delivery, and then 2, 4, and 6 months, or 3, 6, 9 months if you like it better, but you need to follow that RPR until it is non-reactive in the baby. So how are we on time, Miss Julia?
We have a little over 20 minutes left, so you've got some time, and then we'll have time for Q&A.
So a typical day for me in Syphilisville, USA, might be a case like this. We're evaluating 2 to 3 babies a week here for possible congenital syphilis. Term infant, born to a mom who had syphilis treated 3 years ago. Mom's RPR was non-reactive in early pregnancy. Maternal RPR is 1 to 2 at delivery. Infant's RPR is non-reactive at delivery. What do we do? Ooh. So you're kind of in a situation where mom has had syphilis, so the IgG doesn't help us. This isn't a false positive RPR. She was non-reactive early in pregnancy, but 1 to 2 at delivery. That could be just essentially pregnancy-related RPR, increase in titer. Remember, as pregnancy progresses, mom's immune system is changing, and so this RPR titer could reflect just maternal, just pregnancy itself, or it could reflect that mom has had a recent infection with syphilis, And that titer, if we check it in another 2-3 weeks, it might be 1 to 8 or 1 to 16 because it's on the way up. We can't tell because all we have is a snapshot in time. The infant's RPR being non-reactive is fairly reassuring, but this is a baby that we would recommend for basic workup. That is the CBC, the CMP, long bone x-rays, eyes and ears, and LP if one of those others is indicative of syphilis. And again, a low-risk situation as best we can tell if the infant's asymptomatic, and we would probably give this baby a single dose of IM benzathine penicillin. Number 2, healthy baby born at 34 weeks to a mom with an RPR of 1 to 4 at delivery. No prenatal care, so we don't have a history of syphilis or any prior studies. Syphilis IgG is not available for 4 days because it's a holiday a weekend. What do we do for this baby? Well, the red flags here are, this is a premature delivery. And we don't know if mom has any prior syphilis. She says no, but the syphilis IgG is not available to help us for a few days. So this is a situation where, again, you want more history, and you specifically would want to go to the Department of Public Health, and each of the regional public health officers has the statewide syphilis database that tracks every RPR that's positive, every treatment associated with it, and they can go back and look and say, yes, this mom actually had syphilis in 2007 and was treated with 3 or 4 doses, 3 doses or 2 doses of penicillin, whatever was right at the time, and then had negative RPRs. So in the last one was 2 years ago. Now we'd be in a case where we have, again, an RPR of 1 to 4 with a prior negative RPR, but a premature delivery. And provocation of a premature delivery should raise the question that is new syphilis infection or another STI the reason why mom has had a premature delivery. If you can't tell, be more conservative, go for safety. And in this case, the syphilis IgG, waiting on that, keeping the baby in the hospital to wait on that, is not reasonable if this was a term baby, for instance, because treatment is not an emergency as long as all the tests come back negative in your workup. But in this case, at 34 weeks, it's likely the baby's going to stay. You're going to wait for that data and wait for the public health data and then make a decision about treatment. You're going to do the basic workup in this case. The same things we talked about before: CBC, CMP, long bones, eyes and ears, and plus or minus an LP. Third case, term baby born to a mom with an RPR titer of 1 to 64 at 28 weeks. So here's a classic primary syphilis provocation of premature delivery. Mom got 3 doses of benzathine penicillin per protocol. I'm sorry, this is a term baby. Baby's born at term, but mom was treated at 28 weeks. I said it wrong. Mom was treated at 28 weeks. She got 3 doses. Mom's RPR is 1 to 16 at delivery, and infant's RPR is 1 to 16 at delivery. So when we think about what is adequate therapy, remember our criteria. One is that mom started the treatment at least a month prior to delivery. So we've got that, no problem. Mom's titer has come down at least 4-fold. So we have that, 1 to 64 going to 1 to 16. That's a 4-fold drop. Infant's titer should be equal to or less than mom's, and in this case it's equal to. Infant has a normal physical exam. What workup does the infant need? This is a case where I would do, again, likely the basic workup. I would call this mom adequate treatment. The basic workup is reasonable, although some physicians may say, I'm not going to do that basic workup. I'm going to let this baby go home and follow it as an outpatient. That's also within the bounds of scope of practice and standard of care to do so. I'm a little more conservative and tend to do the workup. And if there's anything in the workup that's not reassuring, that is if the platelets are low, liver enzymes are high, the bones are abnormal, or hearing tests or ophthalmologic exam is abnormal, then I'm going to treat. And then I'll make a decision about whether it's a single dose or a full 10-day course. Complicated cases. And finally, a term infant born to a mom with a history of syphilis 5 years prior. Mom's RPR was 1 to 2 early in pregnancy and OB treated her with 3 doses of benzathine penicillin. Her RPR was 1 to 4 at 32 weeks. So it's gone up 1 dilution. She got 3 more doses of benzathine. At delivery, it was 1 to 4, and she got another dose of benzathine penicillin. And baby's titer was 1 to 2. Infant is normal. CBC, CMP, LP are all normal. VDRL is pending. What do we do for this baby? Well, in this case, mom's gotten an awful lot of penicillin during her pregnancy. And this 1 to 2 and 1 to 4 during pregnancy, first point is that may be just that she's serofast, that she's always had a low titer, that her RPR after treatment 5 years ago never came back to undetectable. And that happens not uncommonly. So we can't tell if she's just serofast. This is the right range for serofast, 1 to 2, 1 to 4. And the second important thing is that a difference in titer of 1 to 2 to 1 to 4 is just a single dilution. So from a laboratory standpoint, a clinical standpoint, that's not a significant difference. And so that 32 weeks getting 3 more doses was not indicated based solely on the RPR. If there was some history or mom had a new primary or secondary syphilis lesion that they were concerned about, that changes things. But based solely on the RPR, a 1 to 2 and a 1 to 4 would not be considered clinically significant difference. Say that another way. If I test mom in the morning and I test mom in the evening and it's 1 to 2 in the morning and 1 to 4 in the afternoon, that's no different. Even though we haven't done anything different, it's just within the bounds of the range of acceptability of the test, the variability of the test from run to run. So a clinically significant change in the titer is going from 1 to 2 to undetectable, going from 1 to 4 to 1 to 16. It's a twofold, it's a fourfold difference, or 2 dilutions, 2 titer dilutions difference is considered clinically significant. So in this case, you think this baby is low risk, gotten exposed to plenty of penicillin during pregnancy, and this would be a situation where I'd be comfortable that the baby go home without any treatment. You've got the workup done, or if you're nervous and don't think the baby will come back for follow-up, then a single dose of benzathine penicillin, again, well within the standard of care. All right, let's go. So finalizing things, remember what William Osler said: the physician who knows syphilis knows medicine. Syphilis is a vexing problem for hundreds of years, probably thousands, but its manifestations are protean. It can look like so many things, especially in adults. It hasn't changed. We're not dealing with syphilis resistance to antibiotics. It's the same old syphilis we've been dealing with. You've got to think about syphilis. I tell people it's spread the same way pregnancy is. So if they're pregnant, think about syphilis. If they're not pregnant and potentially could get pregnant, then think about syphilis. You've got to think it. We all have a part to play in curbing STI rates. It really starts with testing. And, oops, I missed it. One more. So why can't we get rid of congenital syphilis? Because we're not doing enough testing and treatment. We absolutely have to do more testing. We've got to get to population level testing, and that's one of the things we're trying to work on, and others are as well. We've got to do more testing so we can do more treatment, and then we'll be able to prevent congenital syphilis. A few resources at the end here. The STD treatment guidelines are available through the CDC website. They were last updated in 2021. Very handy mobile app that is free. It's your tax dollars at work. It's continuously updated. That's a good reason to use the mobile app. And it has not just the treatment regimens, but also diagnostic considerations for all STIs that you can think of. And then the last is the National STD Curriculum. This is from the University of Washington in Seattle, their STD Prevention Training Center. It's funded by CDC, but as you can see at the bottom, each STI, STD has its own chapter, quick references for information you might need, a self-study, and a question bank. So this is CME credit available for free, focused on each of the STIs that you might name. There's HPV, there's HIV, all of these are trichomonas, et cetera, are all listed here. And available for CME at any time that you need a few more CME credits to complete your year. Just go to this website, run a few through, and buff up on your education, and you'll be ready, and you'll have your CMEs for free. So with that, I will stop sharing and pass the baton back to Julia and be happy to answer some questions. I see a few things in the chat. I'll go to those first. So, oh, Julia, you're going to feed them to me? Let me go to the chat.
Yes, so the first question I see is public health tracking of contacts with budget cuts? Or how is public health tracking of contacts with budget cuts done in terms of multiple sex partners in Louisiana, and has follow-up?
So the state receives federal funds to help support contact tracing. There has not, that I'm aware of, been any cuts to health tracking of contacts. When we looked at it in our area, and I've worked with our team's public health team pretty closely, the average number of sexual partners for a new syphilis case is 5 to 6. So that numbers of contact tracing gets very large very quickly. But the basic mechanisms are still in place at the state level because of federal funding that is required. Has studies on education of high-risk population or studies done by agencies? Yes, so there are educational interventions are only modestly helpful. Really, we have to do more. It's got to come from physicians and nurses and providers in all manner, and we have to think about how do we get more testing done. And until we have more testing, things are not likely to change.
All right, the next one I see is, do you recommend obtaining a routine RPR on infants whose mothers have been diagnosed as having a false positive, just in case it was incorrectly diagnosed as false?
So that's a challenging situation. You would, so for instance, if I had an RPR that was 1 to 2 in mom at delivery, and I did an RPR test on the baby, it might be 1 to 2, it might be 1 to 1. And it still could be a false positive in mom. So the RPR alone doesn't give you, RPR in the baby doesn't help you sort out whether mom's is a false positive or not. Said the other way, it's not unreasonable, especially if that IgG is going to be delayed, or whatever your treponemal specific test will be delayed in getting results. Then yes, if you're thinking it's a false positive RPR, go ahead and get one on the baby, because if it's 1 to 16 or 1 to higher, 1 to 8, 1 to 16 or higher, then you're going to say, okay, that's not a false positive. That's more likely a real RPR, and we have to pay attention to that and treat the baby.
Okay, another question, how can we access the database for maternal treatment in Louisiana?
So that is all handled through public health, and every public health region has a DIS, disease intervention specialist, through the public health offices who have that database, and you have to access it through them. I have our guy here in Region 7 is Charles Jones, and he's on speed dial, and I post his number every nursery and hospital that I go to where I have to do a discussion about congenital syphilis. Post it on the wall in the nursery. The nurses should be comfortable calling to get that history from public health. I see Dr. Pichalinge's comment. OBGYN is beginning to do a lot, especially in our academic centers. They are, we think, overtreating for babies who are serofast. They're worried that they're going to miss something and then be sued. I should say moms who are serofast, they're worried they're going to miss something and be sued over it. And so part of this is mitigating that exposure, because ultimately the more antibiotics we use, then we know what the two-edged sword is there. We've got more microbiome effects and resistance and other things. So overtreatment, while it is not the worst thing in the world, we do want to be judicious in our use of antibiotics.
Okay, and one last question that I see in the chat, is an ID referral recommended for all infants with suspected syphilis / infants that are getting serial VDRLs on?
So I think it's really a judgment call, and it's partly your comfort with taking care of the baby. If there are significant complications, then I would say yes, ID referral is helpful, because we may want to do more neuroimaging, especially, or other things. it often doesn't change management, but a lot of times it gives you as the provider and the parents a reassurance that, okay, everything's done, the treatment is done, the baby's looking good, and from an infectious disease standpoint, they don't have to have long-term follow-up. Serial VDRLs, for babies who have a positive VDRL, we do still recommend that they have a repeat LP at 4 to 6 months out and after treatment, and if it's still positive, consider treatment. Those should definitely go to an ID doc. Those are a little more challenging to sort out. So I would say don't hesitate to call us. We never mind.
All right, one more. Do babies who receive benzathine penicillin need a follow-up titer?
Yes, absolutely. Any baby who's exposed needs titers, and any baby whose treated with penicillin definitely needs titers. And as I told you, we had one recent case where baby got treatment and came back at 2 months and the titer was even higher, and that was a treatment failure that we can't explain, but it does happen. It's not common, but it does happen. And so you definitely want to follow those titers until they are non-reactive.
All right, I think we've covered everything that's in the chat. So if anyone has an additional question, you're welcome to unmute and ask those questions now.
And Dr. Pichalinge is with us. She may have other words of wisdom or tips. She and I are working together on congenital syphilis every week.
Yeah, so I had a joint session with OBGYN. They were admitting to be overtreating patients because I think that they don't do this, as you were explaining, not everybody needs a 3-weekly dose of penicillin. And then talking about this patient, I had a patient that even was consulted by adult ID because she has AIDS, HIV/AIDS. And the ID note was really clear. This patient is serofast, has been 1 to 4 for more than a year. The poor thing have received penicillin like uncountable doses.
Right.
And interestingly enough, that I don't know if they, again, as you were saying, they are afraid of missing diagnosis. The CDC does mention that even for the patients that require, pregnant women who require on 1 dose, if they are primary, secondary, or early latent, you can give a 2nd dose after 1 week. So they are basing their decisions on that, but I was telling them, try to stratify who actually does need 3 doses versus the ones that you're treating as not late latent. But then I don't think they have any notion about serofast.
Right.
So they just treat. And the other thing that that case that we have recently that had a relapse recurrence actually was a baby that most likely had a mom had a recent an acute infection just around delivery. Titers were low both on mom and the baby, but the baby had a positive CSF VDRL. So that baby was treated for neurosyphilis, and then the titers went up. Finally, I just saw them like a week ago. I think the baby's like close to 9 months, and finally they are non-reactive. It took a while, but that can happen in some cases. So it's really critical that everybody in Louisiana gets an RPR at delivery, especially when you have these patients with a history of syphilis. And then I think everybody should have a contact with their local Department of Health. Like I have on my cell phone the number of that person who has all the information. So if you go to the website, you should be able to know who's on your local authorities. And there's somebody who's assigned, and like in our case is Mr. Charles, and he already has my number, and we confirm with him the data because sometimes you don't have any records, but everything is reliable from the Department of Health.
Yep. Very good. And Dr. Hebert-McGee, I see you're with us. Appreciate you being with us. Any thoughts, comments? For those who don't know, Dr. Hebert-McGee is the Medicaid medical director for the state, and she's been intimately involved in our discussions about how to deal with this vexing problem of congenital syphilis. May have had to step away. All right. And Dr. Legarbo?
Hello, I'm here. It was excellent. Thank you, Dr.
Nope.
Vanchiere. And I think that you know that the health plans are already taking steps to make sure that we support the obstetricians any way that we can to make sure that these screenings are done. And that's across all 6 health plans.
Very good. Thank you very much. All right, Julia?
Okay, we'll go through our last little bit of housekeeping. Make sure you take your evaluation. I have already dropped the evaluation form code in the chat. The evaluation helps us to continue to improve and is how you claim your credit. If you do not have an evaluation, we don't have enough information about you to upload your credit to CE Broker or to send you a certificate. So please go ahead and do that. Next, our next webinar will be not part of this Gumbeaux series, but an evening webinar next week on boosting public discourse, evidence-based strategies for reframing child and adolescent immunization with Julie Sweetland from the Frameworks Institute. She is part of the team that worked with the National AAP to develop this framework of how to talk on the public stage about immunization and how that's different from talking in your clinic one-on-one about immunization. Our next webinar in this series will be with Dr. Pinky Prasad from New Orleans about how to take care of the childhood cancer survivor. We are looking forward to that. And that will be Thursday, March 14th at noon. After that March 14th webinar, we will take a break. We usually do this every 2 weeks, but we'll take a break for Easter week and be back in April. Our next conference will be August 16th through 18th in Alexandria. Our call for proposals is now closed. We got a lot of great proposals, and we are excited to share what we will be doing there. You can learn more at laaap.org/2024 potpourri. And that is now in the chat. And finally, all of our on-demand education is available on our website at laaap.org/cme-courses and on our YouTube channel, which is linked here. Please go ahead and check that out. All of our previous webinars in this series are available there. And this one will be up within a week or so. So that you can share it with your friends and colleagues who need to know more about how to combat congenital syphilis. Okay, that is all. I'm going to put you back on the evaluation link so you can scan that. And we are done. Thank you, Dr. Vanchiere, and everyone who pitched in to help with the question and answer section. We are looking forward to seeing you in a couple of weeks for the taking care of the childhood cancer survivor, and next week for boosting public discourse.
I dropped my phone number in the chat, so if anybody doesn't have it, don't feel left out. Now you have it, and you're happy. I'm welcome to hear from you. And if I can't answer the question, Dr. Pichalinga definitely will be able to answer it. Thank y'all.